So typical motor changes following a spinal cord injury, you're usually going to have spastic hypertonia, and that's in about 65% of patients with spinal cord injury. And that's a motor disorder characterized by a velocity-dependent increase in tonic stretch reflexes, like muscle tone. You're going to have exaggerated tendon jerks. It's going to result from the hyperexcitability of the stretch reflex, and it's one component of an upper motor neuron syndrome. It occurs below the site of the lesion. It usually reaches a plateau like 1 year after the injury. And there's questionable evidence for stretching to treat it. You can't just grab the arm and stretch it like that because it's velocity dependent. It's nothing like rigidity or anything like that. Pharmacological agents can cause some pretty serious side effects, so they have to be careful using those. Usually surgical interventions require a tenotomy or a myotomy. They usually just cut the tendon or take the muscle out or reduce the size of the muscle. Injuries below T10, you're going to have normal ventilation. We're talking about motor control of the diaphragm. Everything above that level, you're going to have some involvement of the intercostals, the diaphragm, or some of the accessory breathing muscles. Along with some of the motor changes, you're going to have bladder dysfunction with some of these injuries. They can either be a hyperreflexic or an areflexic bladder. This is pertinent to fall risk because these patients might have catheters or external bags or tubes or anything like that that might get in the way of their ambulation.